It is a great privilege to be here today, guys. I think most of you guys know me, so we'll get started. I like to start off with a disclaimer. Unlike Dr. Brown, I was not breastfed, so any poor quality of my talk, just bear with me. These are our objectives, and I'm not going to bore you going through them. I have quite a bit of slides, so we're going to try to zip through them and do the most important ones and spend more time on them. But the biggest thing I want you guys to leave this room with is the knowledge and understanding that a woman with a BMI of 60 is not the same as one with a BMI of 25. We shouldn't treat them the same. We should not think of them the same. And hopefully by the end of my talk, we'll have some understanding on that. We're not unfamiliar with the obesity epidemic. It truly is an epidemic. We have increased exponentially, and as you can see, let me see if I get this, there we go. We're right in the middle of it. So about more than 30% of our population in Tennessee is obese or morbidly obese at this point. So it has gotten worse and worse. We're making America great again, unfortunately, in the wrong things, and we're getting huge. But the good news is that the rest of the world is following right with us. So we're not alone. We're ahead of the game. These are sobering statistics. 2 out of 3 women in the U.S. of childbearing age is overweight or obese. I mean, that is just astounding. In talking on obesity in women primarily, we need to be aware that it affects different ethnicities disproportionately. Caucasian women, about 30%. Hispanic Latino women, 40%, and African American women is close to 60%. So we need to keep that in mind. This slide, we'll go quickly through it. Very important slide. Risk to obese women with obesity in pregnancy, diabetes, hypertension, preeclampsia, prolonged pregnancy. This is one that I think we need to spend a little more time with. Depression, anxiety. Morbidly obese women at much higher risk for depression, anxiety, abuse, neglect. Talked about sexual dysfunction earlier. So this is one that we need to spend more time on. Risk to the baby, risk of congenital anomalies. We're familiar with neural tube defects. Cardiac anomalies getting more and more attention from the literature. Macrosomia. Babies born to obese moms have a much higher risk of lifetime risk of diabetes, heart disease, obesity, risk of IUFD in the 3rd trimester, risk for spontaneous and iatrogenic preterm birth. So what I thought for this talk, we'll just come up with a patient. Let's say that we have Susie, who is in her early 30s, and Susie's got a BMI in the high 40s. So we'll see Susie before she becomes pregnant. She gets pregnant. How do we deliver Susie? What complications Susie may have after her delivery, etc. Important note here on contraception. Just be aware that most contraceptive options are safe for obese and morbidly obese women. So we have a plethora of options. And also we need to be aware of the fact that women that are overweight or obese have a mental block. They have the preconception that they're going to gain a lot of weight by birth control, and that may stop them from asking. So in our visits, we should always be asking them regarding contraception. Bariatric surgery has been a very, very effective way of treating obesity in our country. It's increased about 800% from the 90s to the 2000s. And women are the vast majority of the recipients of these procedures. 80% or more of procedures are done on women. It is generally advisable for women with a BMI greater than 40 or greater than 35 if they have comorbidities. We're blessed in Chattanooga. We have a couple of excellent bariatric surgeons, very, very eager to work with your patients. I have referred a few to Dr. Sanborn, in particular Erlanger, and they've been very, very successful. We have two types of surgery, the restrictive procedures and the malabsorptive procedures, the Roux-en-Y's. Most of the procedures nowadays tend to be on the restrictive category, which is a good thing for us obstetricians because they tend to have fewer complications. The effect of the bariatric surgery on fertility is wonderful. Rapid weight loss usually ensues, improves PCOS, improves anovulation, irregular menses, much higher fertility rates. Important to tell our patients, even though things are going great and you're going to become fertile, try to not get pregnant for at least a year, okay? This environment of rapid weight loss is not a good environment for the developing embryo, and the complication rate increases exponentially. So if you can keep them from becoming pregnant for at least a year, two even better, be a good thing. So Susie comes back, and now she's pregnant. We said for BMI is like 48, let's say. So what should we tell her? What should we advise or counsel her in regards to how much weight gain she should be gaining in pregnancy? We're very familiar with the Institute of Medicine guidelines. I'm not going to go over all of those. But this is the part that's bothersome. Whether your BMI is 30 or it's 80, we're still recommending that women gain weight as high as half a pound per week in the late second to third trimester. And we know that that necessarily is not beneficial to women, particularly when we look at complications during pregnancy and postpartum, weight retention, etc. Don't get me wrong, weight gain is important in pregnancy. We know this. It's been associated with better outcomes. But we confuse weight gain with proper nutrition. And that's what we need to emphasize on our patients. It's not just about gaining weight, it's gaining the right kind of weight. Always remember that inappropriate gain merits more questions. We are, as providers, we are terrible. We're embarrassed to talk to our patients about their weight. Nobody wants to discuss it, nobody touches it. Patients are very in tune to what their blood sugars are, what their blood pressure is. Weight, we just forget about and not discuss it. It is a vital sign. We should discuss it at every prenatal visit. And options we can do, we can even do weight charts and kind of help the patient plot herself what her weight is doing. Maybe that'll bring it to her attention a little bit better. So we need to emphasize this, reinforce, and provide guidance to your patients. This weight gain guidelines have changed over the years. So if we look at the 1940s and 50s, uniformly say women should gain less than 20 pounds. The idea was decreasing macrosomia, decreasing toxemia, preeclampsia. In the 70s, kind of uniform for everybody. Said 24 pounds across the board, doesn't matter, with the emphasis on decreasing the risk of SGA and IUGR babies. In the 1990s, we got a little smarter. We decided, hey, let's advise our weight gain based on your pre-pregnancy weight. So thinner women need to be gaining more weight than heavier women. Once again, the outcome bias towards birth weight. This is a graph from a paper by Dr. Liu that came in the early 2000s. One of the first articles in our literature looking at obesity in pregnancy. This didn't copy very well, but you can see that these are a chart from 1980 to 1999, I believe. Intake of pregnant women across the board. Women that weighed 300 pounds at intake went from 0.5% to 6%. Women that weighed 250 pounds went from 5% to 12% of all women. And that was 15 years ago, so it's just the graph got to look worse. So, how does the OB care really really contribute to this obesity crisis. What can we do? Always try to reemphasize the fact that, and this is also something that I think we forget, a full-term pregnancy, baby, placenta, amniotic fluid, only should account for about 10 to 15 pounds of the weight gain. So that kind of should bring it a little into perspective as to what we need to be doing and what we're doing wrong. These guidelines are meant to decrease the incidence of SGA, IUGR infants. They do not look at excessive LGA rates. They do not look at weight retention by mothers. And in some cases, they're recommending, for example, populations at risk, like teenagers, which have an overwhelming amount of obesity right now, to gain more weight during the pregnancy just because they're teenagers. Nutrition is what we need to hone. And we know that good nutrition is important not only for short-term goals, but also for long-term goals. Poor nutrition has been associated with prenatal problems, delivery problems, postpartum complications, bad birth outcomes, preterm delivery, low birth weight, IUGR, macrosomia, obesity. Dr. Brown hinted on the Barker hypothesis and the fetal origins, the effect of obesogens in the uterus, and what effect that may have for the fetus later in life. And this is a very exciting area where we're learning more and more every day. And also psychological outcomes for babies born to obese mothers. Increased risk for ADHD, for example. So I'll briefly touch on nutritional overviews during pregnancy. Protein intake should increase somewhat in pregnancy. Usually not a problem in our culture because most folks eat meat. Iron should double. Vitamin A, C, Bs, minerals and fibers should increase. Flora, calcium, about the same. We'll pass that. Folic acid is important to mention, of course, especially in the obese population. We all know that the standard recommendation by the task force of about 400 to 800 micrograms per day. It works. We know it. Nobody's going to question that. And we have decreased the risk of neural tube defects by about 25%. The problem is getting folate naturally is very difficult. You'd have to drink about 7 cups of juice. That's about 1,000 calories a day or more. Eat 18 cups of raw spinach or 6 cups of kidney beans for you to get those requirements. Problem comes is when we're getting into the morbidly obese category. And some authorities are questioning whether even 800 micrograms is sufficient. And some folks are recommending doing 4 grams, just like we would do someone with a history of a neural tube defect. So something that, like I said, a few of the things that we're going to be talking about, we have no compass. We're like lost in the sea right now. We don't know what is best to do. So long-chain polyunsaturated fatty acids, we know that are important for fetal brain and retinal development, particularly in the 3rd trimester, and also preconceptionally. As a society, as a whole, we eat very little fish. ACOG recommends 2 to 3 servings of fish per week. Say, I don't think we get nearly that amount, so that's important to supplement as well. Iodine intake, also important. We need to be aware of the fact that most everybody nowadays is getting their water from bottled water, and bottled water doesn't have any iodine in it. So at least ask them to get salt that has been ionized. Calcium requirements really don't increase very much, so we won't bother. Vitamin D, we get it through sun exposure, fatty fish, fortified milk. This is something that we know that we're deficient. So if you have someone that is obese or morbidly obese, probably not a bad idea to supplement them with extra vitamin D. Iron deficiency is very problematic, and it affects morbidly obese women disproportionately. We know that women that are iron deficient anemia have decreased ability to tolerate hemorrhage, increased risk for uterine atony, slower wound healing, decreased immune function, postpartum depression. We know that it affects the baby as well. In cases of severe iron deficiency anemia, we can start having problems with fetal oxygenation, asphyxia, increased mortality, etc. The typical adult intake in our country is about 15 milligrams per day, when we should be actually consuming double. Part of it is that iron is poorly absorbed by our body, and supplements even worse. So we have to keep this in mind when we're discussing iron supplementation to our patient. The therapy is always poorly tolerated. Most folks that you put on iron stop the therapy after a few days of being on it. Enteric-coated iron supplementation does not work as well. And there's also some association with taking all your medicine at the same time, especially when you're taking iron supplements and prenatal vitamins. Some minerals in the prenatal vitamins like calcium, selenium, etc. can affect the absorption of iron. So you can tell them if you're going to take iron, take it at a different time. It is better to talk to them about nutrition. What are good sources of iron? Green leafy vegetables, they're in season now. We have kale, we have broccoli, we have Brussels sprouts, etc. But more importantly, meat. If they're meat eaters, these are absorbed better. So up to 35% absorption with a heme type of iron. So we had that discussion. Now Susie is pregnant and we need to take care of her. So what is Susie at risk for? We know that with pregnancy, first obstacle is difficulties in determining an estimated date of confinement. Irregular menses, late prenatal care, you name it. First trimester losses, much increase in this population. Background comorbidities, chronic hypertension, the so-called gestational diabetes. We're seeing more and more gestational diabetes consults like 10 weeks of pregnancy. So, you're probably not gestational diabetic, but pre-existing. Twinning, neural tube defects and other anomalies, weight gain we discussed, and difficulty with antenatal testing, just to name a few. So what are things that we can do? Paramount to do an early ultrasound on these moms. Verify dating as accurately as you possibly can, and rule out the possibility of twinning. Early diabetes screening. If the very least you can do, order an A1C with your prenatal labs. At least that'll get you somewhere. If not, just do the standard glycemic testing early, and then if normal, you can repeat it at the usual interval. Encourage genetic testing and anatomy screen for anomalies. I know a lot of our patients are not interested in genetic screening, but we should push them at least for the AFP. These ultrasounds are not easy, guys. And where's Will? He may be outside. Will Powers with GE here. Ultrasound machines are getting better and better and better, but our patients are getting larger and larger and larger. It is extremely difficult to image these fetuses. And sometimes it takes us 2 or 3 ultrasounds before we can document the whole anatomy. There's nothing we can do about it. So the nutritional counseling, as we discussed. During the pregnancy, much higher risk for preeclampsia, diabetes, twinning, excessive weight gain, poor nutrition, difficulty with ultrasound, antenatal testing, metabolic syndrome, fatty liver. We're seeing more and more consults from fatty liver in pregnancy. Woman comes in, morbidly obese, liver enzymes in the 100, 200 range. Hepatitis workup is negative. Increased risk for preterm delivery, both caused by us, doctors, and also for spontaneous, and also for third trimester IUFDs. And that's a tricky one, because we really don't have any guidelines as to what to tell our patients to decrease their IUFD. Fetal kick counts, should you do NST, what BMI, when, how early, how often? We just don't have those answers. So our discretion, I know we're trying to push for evidence-based. Sometimes you just have to throw the evidence-based to the side and just do what's right. And like I said, we may not have the evidence, but do your best. Serial ultrasounds are very important to assess for fetal growth, not only for macrosomia, but also a vast majority of this morbidly obese population have growth-restricted babies because they have such poor nutrition. Monitor for developing preeclampsia, antenatal testing we discussed. You know, should we have a uniform policy for induction at 40 weeks because of the increased risk of IUFD and the problems that brings, particularly in the obese population? And we'll talk a little bit more about the difficulties during labor and cesarean. So now Susie is pregnant. She is in labor, and she's coming to your hospital. So what is she at risk for with a BMI in the 40s, high 40s we said. So need of induction of labor for comorbidities, blood pressure issues, poorly controlled diabetes, fetal growth restriction, etc. What do we run into? Number one, all nurses here, or anybody that's working in L&D, is difficulty monitoring these guys. It is just technically difficult. We know that their C-section rate is increased threefold and their failed toe lag twofold. So that is something that we need to emphasize, and we had a great talk on VBAC. We got to pick the right candidates. Surgical risks, infection, injury, operative time, anesthesia risks, birth trauma from macrosomia, twinning and their complications, postpartum hemorrhage, risk for DVT. Should we be anticoagulating these patients, like Dr. Brown alluded to? Should we do SCDs? Once again, there's no definitive data as to what we should be doing. If we are doing VBAC and they're interested in VBAC, be upfront with them. Tell them your risk for being successful, if you're morbidly obese, is decreased at least by 50%. Have to keep those numbers in mind. If you have a bad-looking strip, be proactive. These C-sections don't happen very rapidly. And we're talking about BMIs in the 50s, 60s. I mean, it is a logistical nightmare, so always stay ahead. Consider type and crossing of blood instead of type and screening due to their increased risk of postpartum hemorrhage. If you're anticipating a C-section, ask for the instruments that you may need. We all have been in the middle of a C-section and we order something that we're used to not having in L&D and know how long that can take. Our emphasis when we're doing these surgeries, as difficult as they are, is to get in and get out. The shorter operative time, the fewer the complications for our patients. So if we order the long set of instruments and it's going to take 20 minutes to get it from downstairs, that's a problem. With that, we also need to talk about the type of incision, and we'll come back to that, the type of table you may need, etc. At the very least, initiate SCDs early. Encourage early ambulation, and in some patients, consider prophylaxis. Be ready for the macrosomic dystocia. You do shoulder dystocia drills with your team if you have a morbidly obese patient, because there's a high likelihood that you may encounter, so be ready. An anesthesia consult is paramount, especially if BMI is greater than 40. We've looked at a couple of large meta-analyses in the literature looking at the rate of obesity and cesarean. This is Dr. Chu et al. Looked at 33 cohort studies, including all parodies, while the Pubulan meta-analysis in 2008 looked at only nulliparous women. But it's no surprise, as BMI increases, that our odds ratio for cesarean section follow. There is a dose-dependent association between obesity and cesarean delivery. Kominarek, in the Gray Journal in 2011, they looked at 120,000 women, multi-site study, There's a 5% increased risk for implant C-section with each increase of BMI of 1 kilogram per meter square. And this is the chart that follows that article. So what? Well, it doesn't end with a C-section. We have to think of all the things that follow. Wound infection, clots, hemorrhage, prolonged hospitalization, infection, endometritis, problems with airway. Once again, 2 to 4-fold increase of complications. But this statistic here is sobering. 1 out of 3 maternal deaths in our country are associated with obesity complications. When 2/3 of all women are obese or overweight, that becomes kind of frightening. So cesarean delivery is not a benign procedure for morbidly obese and obese women. ACOG recommends early anesthesia consult. We know that a failed intubation in non-obese patients has a failed intubation rate of 1 in 300, whereas for a obese or morbidly obese woman, about 1 in 3 may have a failed intubation. So intubation in obese women requires a much higher level of skill and preparation. Quickly, I'm running out of time here, so we will review some maternal physiology here. The residents love me for this, but a couple to remember here: the functional residual capacity on obese patients is much decreased, and total lung capacity. So if you have a failed intubation, you have a profound hypoxemia, both for mom and for fetus. Also, cardiovascular changes in pregnancy. Obesity kind of changes things. We see that normally we would see systemic vascular resistance to drop. In obese women, it goes up. The body's trying its best to try to perfuse all her organs and baby. So in a preoperative evaluation for the morbidly obese, consider any signs or symptoms that you may see on your physical exam. Get a workup, EKG, an echocardiogram, do a good physical examination, get an early anesthesia consult, look at their airway, discuss invasive monitoring, etc. So this is our patient, and unfortunately she did not do well in labor, and now she's in our OR table. So that's where we come in. You can see the importance that it is to obtain some left displacement. If we lay a morbidly obese woman supine on her back, the amount of pressure of that pannus and the impact that has on vascular return is huge. So we need to keep that in mind. The same as positioning for intubation. So what approaches should we have for C-sections in the obese and morbidly obese? Number one, you have to have the right bed. You have to have the right anesthesia. You have to have the right assistance. Don't be embarrassed to ask for more than one assistant. I mean, sometimes you just need the extra help. Availability of blood products. Assess the type of obesity as to how their pannus lies and what type of incision you may be utilizing, and have a plan. That's the main thing I want to hone in is have a plan. Don't treat this as your run-of-the-mill C-section. These are different. They definitely carry a higher level of risk. You may consider doing them in the main OR. We've done that several times, just to have more availability of equipment and support. So what incision should we do on our patient here? And that's the tough question. You know, over the years when we were dealing with morbidly obese women, we always shied away from the phanestoid incision, thinking that the pannus overlies it. It creates a hypoxic environment, moist, it can cause infection, etc. So other approaches have been looked at, inclusive of the supraumbilical, the transverse, a vertical incision. So So what's best? Newer literature points to the fact that phanestyl may not be the worst choice for these patients. Actually, if you can get by with a phanestyl incision, perhaps you should consider doing that on the morbidly obese. The problem is the type of obesity, how their PANAS affects your incision, and weight. When you get into a patient with a BMI of 50, 60, 70, you're not going to be able to do a phanestyl. So you have to have a plan B, C, or D. Obviously, transverse incisions, vertical incisions carry morbidity. They're more painful, slower healing time, decreased ambulation, increased risk for clots, etc. So it all comes with their pluses and their minuses. Also be aware that when you do a very high incision, you may not be at the lower uterine segment when you're delivering the patient. Big problem, and something that you need to discuss, because if your patient tells you that they want to become pregnant again, and you do a high transverse incision, you may have to do a fundectomy to deliver the baby. And what problems is that incision going to have for their next pregnancy? So that also should play a role in your decision making for what type of incision. Usually if we do that approach and we do a fundectomy, I really want to do a tubal ligation on those patients if they consent to it. Subcutaneous closure, the literature advocates for doing this, usually plain gut. The drain or not to drain. We think that drains are not as good or beneficial as we thought. And actually they may be counterproductive. They may introduce infection to our incision and really not clear benefits. So the literature appears to disfavor the routine use of drains. Suture type, usually a strong monofilament, PDS type suture for the fascia. Skin closure, I prefer staples. We use vertical mattresses sometimes for morbidly obese patients. And the post-op care, I think, really brings on what Dr. Brown was alluding earlier. These are not the patients you want to say, I'll see you back in 6 weeks. You need to bring them back sooner. Usually they have other comorbidities as well. I'll finish off with, why do women fail labor? And we know what labor dystocia is caused by the 3 P's: passage, passenger, and power. The first P, the passage, we have soft tissue obstruction. So that can be a problem for sure. Passenger, macrosomia. Power, we'll spend a little more time on this, is that obese and morbidly obese women have dysfunctional myometrial cells. They don't work as well as they should. The effect of leptin at cholesterol is something where new data is telling us that elevated cholesterol, as we often see on these women, can cause problems to myometrial cells, as does leptin. So 4 models for looking at this. Cholesterol causes abnormal contraction patterns. Leptin can disrupt contractility and affect cervical ripening, and also cause a decrease in the oxytocin receptors. So these women are basically set for failure in a way. So we need to take that into consideration. This is a electrophysiologic model. Normal BMI, you can see contractions start up at the fundus and neatly go down to the lower uterine segment. This is a morbidly obese uterus. Contractions are all over the place. The myometrial cells are confused. The number of interventions in obese women obviously much increased, and really no evidence to support a lot of the things that we're doing. So in talking on induction of labor, we need to understand that these inductions are going to take a long time. We do not need to put a normal BMI and a BMI of 60 in the same category, because it's not going to happen. I'm getting my signal here that I'm way over my time. But with this, we need to understand that obese women have a much, much slower labor curve. And when we look at, this is the problem, from change from 4 to 10 centimeters, it's much, much, much prolonged in obese people. As long as mom is okay and baby is okay, take your time. If they're making some progress, but they're going to move much slower. Second stage doesn't seem to be as much of a problem. So once they get to complete, usually they do okay. So we'll cut it short at that. Thank you for your time. Sorry for running